I'm very happy to introduce Dr. Fatma Marun from the National Genome Center of Bahrain. And she's going to be talking to us in more details about National Genome Center, what has been done before, what are the plans for the future, because there is something new that's being launched, and we are very happy and proud that Bahrain Specialist Hospital is the first hospital to be contributing to the new step in the National Genome Center in the private sector. So I'll leave it all to you, Doctor.
Thank you, Dr. Qasim. Well, good morning, everybody. I'm very happy and pleased to be here with you today. Yep. Okay, no problem. And I would like also to thank Dr. Najah and Dr. Qasim for their collaboration and very warm welcome. My name is Dr. Fatma Marun. I am MD, a graduate from Arabian Gulf University. I continued my education and training journey, and I have entered the field of genetics and rare diseases through genetic counseling and personalized medicine. Alongside other stuff, I am also a TED speaker and autism activist globally and regionally. So I'm here today because along the centuries, we have seen multiple revolutions. For example, the Industrial Revolution, the Agricultural Revolution, Physics Revolution. But on the medical side, we are seeing a new revolution coming out through genomic medicine and personalized medicine. And here in Bahrain, we are not that much behind from the rest of the leading countries in the world. So I'm here today on behalf of my team from the National Genome Center in the Ministry of Health to widen your perspective and give you an insight about our national genome programs and how can you contribute as Bahrain Specialist Hospital in our programs. So let me begin by my favorite quote, which is, medicine is a science of uncertainty and an art of probability. So medicine has changed the face of the healthcare that we know from the days of the pyramids and the pharaohs and the discovery of diabetes, and along the way, a very rich history in the centuries in European countries, Middle East countries, and all around the globe. There has been a part of uncertainty, like we are facing what we don't see, what we don't understand. But then with the discovery of the microscope, we have started to realize we are not alone. And when we get sick, there is a causative element and an element of microbiology. And the knowledge did not stop there at the microbiology only. We started to think about how can we unlock the secret of life? And to do that, we started to, let's say, it's actually a new field. And it had been discovered in the 1945 by Watson and Crick when they discovered the structure of the DNA. And then they have linked it as the DNA is the block of life, and it is the secret to unfold everything related to health aspect. So currently, what are we practicing? As we all know, we are currently practicing the modern medicine, which have been revolutionized in the 19th century till nowadays. And it has multiple chains and aspects that we can all relate to. For example, when a patient presents to us, we are lucky to have standardized treatments. For example, if somebody is having dyspepsia or upset stomach, we know that there are first-line drugs and the standard doses that we can help the patient immediately and relieve their pains. And you can measure it along the other diseases also. We have a broad availability. We have a lot of people who are now, like yourselves, are specialized in multiple specialties in depth to take care of that body organ or body problem. For example, we have the cardiology, oncology, surgery, and pediatrics, obstetric and gynecology, and all of the other fields. We have established along the last century the infrastructure. We have a primary healthcare, we have secondary and tertiary centers as in hospitals and institutions. We have also revolutionized and laid the block for research centers, which can help to transfer the knowledge, the medical knowledge from bench side to bedside. We have found some immediate solutions. For example, a patient with, let's say, severe dehydration, you can immediately relieve the dehydration by IV line, for instance, which was not a privilege for those who lived, for example, in the days of the pharaohs. And we have regulatory oversights, meaning we have institutions which are regulating all of our modern medicine practices. For example, FDA approved drugs and regulations, WHO, and all of the other medical institutions which oversight our current practices. So where is the problem in modern medicine if everything is rainbows and we are doing fine and we are treating patients and we are doing everything up to the standard? Well, let's magnify it. We actually have fallen in a very big pitfall when we standardize the treatments, because we have made it one size that fits all. But actually, all of us, although we are all humans, but from the inside, we have different and very unique genetic makeup. For example, if you are having Asian ancestry or ethnicity, your genetic makeup is similar to all of the other ethnicities, but you are unique in that portion. If you are from the Middle East, it applies the same. If you are from Western countries or white ethnicity, then you also share some, but you are different in your own genetic makeup. So it gives us also the pitfall that if I delivered for you a specific treatment which was developed in a specific setting and it was working there, it might not work here in this setting. So the first rule or the first limitation is that one size does not fit all, because it can cause to some populations great benefit, great treatments, but in other populations, it can cause severe side effects and even can cause mortality in severe cases. We have developed the modern medicine to be a reactive system. For example, we are not trying so much to be proactive and to detect the thing before it happens. Although we have just finished the October, which is the month of breast cancer awareness, and we are all saying the same motto: early detection, early diagnosis can save lives. It can increases the curation rate up to 95% if it was detected early. But what if that was not the case? What if we took a step forward and we tried to detect and prevent diseases before the manifestation? What if we took one step forward and tried to address the diseases before they occur at the early stages even? So the adverse reactions, they contribute to around 5% of all hospital mortalities. And 5% is not something that is neglectable or that we can underestimate. From any 100, for example, patient go in hospital, 5 of them might suffer from severe adverse reactions. So since the 1940s, genomic medicine started to evolve, and it is promising in the following areas. Personalized treatment, meaning if I'm having an individual at this moment of time, I will be delivering to this person not the standard dose, not the standard treatment, but I will be trying to tailor a specific management according to his genetic makeup, which is more accurate, cost-effective, and it saves a lot of, let's say, time, effort, and also financial resources. Instead of being a reactive medicine approaches, we will be more of a preventive focus. We will also understand the disease mechanisms. Instead of treating the signs and symptoms after they appear, we understand and treat the biology and the etiology of the causative, let's say, mechanism. We can also enhance the drug efficacy because a new field is also evolving called the pharmacogenetics, which is in Arabic الصيدلة الجينية. It means that all of us are digesting the same medicines if we were prescribed the same medicine, but we have a specific genes that codes for specific enzymes to break down those drugs. All right, you see the link? So we share the treatment, but we have different genes from each one another because everyone here in this room is unique. So some of us might be, for example, normal metabolizer for that specific drug, and other people, and this normal metabolizer would be benefiting from the standard dose. But on the other extreme ends might be poor metabolizer, or for example, ultra rapid metabolizer. So it means it's either they will need an increase in the dose or they will develop a side effect which requires alteration of dose or choose an alternative medication. It will help also in informed family planning. Instead of waiting for a test result after having an affected child with any genetic disorder, if we have the genome for all of the family member, we can have an insight in the future and provide the family with knowledge and power to choose their reproductive choices. So is the genomic medicine that promising but has no limitation or challenges? Of course not. There is always a pros and cons for everything. So some of the challenges which we are currently facing in the genomic medicine is the price of testing and accessibility. Unfortunately, genetic testing is not an option for a lot of people around the globe. It has limited access by financial resources and by insurance coverage, which in some countries it is covering and in others it's not. We have also some challenges and difficulties in genomic interpretation because not all of the diseases are monogenic diseases, meaning a monogenic disease, for example, a very well-known disease here in Bahrain in blood hereditary group, it is called sickle cell anemia or sickle cell disease. It is under the category of being a monogenic disease, meaning one gene equals one disease. But on the other end, there is an NCD disease called diabetes mellitus, which is a complex disease and a polygenic disease in the same time. It means that it is one disease, but it might be caused by, for example, 100 variants or 80 variants. So interpretation of genetic results, it needs a specialized person, a dedicated analysis team, and it also needs to be addressed in a professional setting of genetic counseling. And VUSs are also the new blocks of genomic medicine, which are variants of unknown significance. So since we unlocked the human genome referencing, which took around 10 to 12 years from 1991 until 2002, they have published the draft of human genome referencing, and then they have enhanced it upon the years up till we reach to the current version nowadays. We have discovered around 22,000 disease-causing genes, but along those genes, we have a specific category called the variant of unknown significance, meaning we are still receiving cases around the globe. It is still not categorized or proven to be linked to be a causative. So it's not benign and it's not pathogenic. It's in the middle, still under categorization. And every 2 years, these VUSs might be updated to either green light or red light. So unfortunately, some populations and some groups of people, when they see, for example, a genetic result and they have a VUS, they think we are healthy. It does not cause a disease. But in fact, if you repeat the analysis within within 2 years, it might be upgraded to pathogenic gene, which means it is disease causing. So these are the tiny bits of challenges in genomic medicine, besides also some worries and some concerns about confidentiality, discrimination, stigmatization of people based on their genetic makeup. And we also have some difficulties to integrate the current modern medicine with genomic medicine settings. And let me draw your attention to a very important point, which is here, variability in populational data. Because the first draft of the human genome was a collaboration between United States, UK, Japan, and a few other countries. It lacked the enough representation of all of the other ethnicities. So what might be a pathogenic variant in, for example, a US citizen might not be pathogenic for a Bahraini citizen to some extent. That's why we need enough representation and enough sampling of Bahraini populational genome. So let me tell you the bright side of the story, since we have took a look now on modern medicine, genomic medicine. Where do we stand currently here in Bahrain? So His Royal Highness Sheikh Salman bin Hamad Al Khalifa, our Prime Minister, and the Crown Prince have launched the initiative of establishment of the Bahrain Genome Center under the Ministry of Health, with the aims of and goals of doing mainly the Bahraini Genome project to build up our own genome referencing and enhance our modern medicine into integration into personalized and genomic medicine. Our goals are innovation in healthcare, proactive and preventive healthcare system, applications of personalized medicine integrated with the application of artificial intelligence, and equal accessibility and fairness to genomic services, besides our strong system which protect the data and confidentiality of those who are participating. So currently in the Genome Center, we have 3 parallel programs are running in parallel into each other. We have the Athletes Genome, which was started last year and is to be due by next year. We have also the main program, which is the Bahraini Genome program, which is a sample of 6K from the Bahraini population, which was started in collecting from 2019, due to be by the end of this year, which is in a month from now. And I will give you also what have been the updates for this. And our newly program, which I'm here today to tell you about with so much of excitement and open doors for collaboration, it is the Genomic Newborn Screening Research Program, which we have launched last year in governmental hospital, in Salmaniya Hospital, in labor room exclusively as a pilot study. And now we are here today to start the phase 2 with the private hospitals, because you are our partners in success to achieve our goals, inshallah. So to begin with, the Bahraini Genome program has a target of 6,000 samples. It is divided into a healthy cohort composed of 4,000 individuals or participants and a rare cohort. Rare cohort meaning those families or individuals which are symptomatic but do have label and others are undiagnosed, meaning they have dysmorphic features, they have multi-system problems and health issues, but there is no specific syndrome or label that applies to them. Or, for example, if you have big families that have multiple individuals who are presenting with the same symptoms, and it seems to be the same disease, but you don't know the genetic makeup of them. So this rare cohort is composed of 2,000 samples or individuals. In phase 1, we have sent all of these samples, and actually we are sending the last batch during this month. We have sent all of those samples to United States of America for our partners in Harvard Medical School, Broad Institute, and the International Center of Genetic Diseases. Because we are currently trying to build up our own local capacity to run the Genome Center exclusively by Bahraini hands, from collecting to sequencing to analysis to reporting. And meanwhile, we have received the results, let's say the primary results of those participating in the Bahraini Genome program. And the results are having 4 categories. The monogenic findings, meaning when they participated and they have declared in the consent that they don't have any disease. In fact, they appear healthy. But when we tested them with whole genome sequencing, they appear to be genetically affected with a monogenic disease. We have also received the genetic carrier status, meaning it's a reflection for their reproductive health. If a carrier marries to another carrier, they will have and it's, for example, an autosomal recessive disorder, they will have 25% chances of having an affected child. We have also looked at the risk alleles and the new field of pharmacogenetics for around 70 drugs, known drugs and used. And currently we are standing at the phase 3 of return of results, which we have received already, especially those results which are actionable and requires immediate intervention. For example, if the person appears to be healthy and consented that he is healthy and we received a monogenic finding correlating, for example, for breast cancer or correlating for cardiomyopathy, then we go through the process of return of result with an urgency for that specific result. If the participant appears to be healthy, his genetic health is fine, no monogenic finding, no carrier findings, then we delay the return of result for that participant because the priority goes to those who need immediate healthcare intervention. And we have successfully returned the results of who came with positive findings in cardiology, meaning cardiogenic disorders. Through our collaboration with governmental hospitals, Salmon. And the same process will go by priority of diseases, oncology, neurology, metabolic, and the list goes on. So, with great pleasure and honor, I'm here today to tell you about our Genomic Newborn Screening Research Program. As the Bahraini Genome program is composed of 2 cohorts, the healthy cohort and the rare disease cohort, also the newborn screening program composed of 2 cohorts. We have healthy babies, or at least they appear healthy at the time of birth. And the process goes on like this. We take the consent from both parents through the prenatal appointments when they are coming for ultrasounds, checkups during a pregnancy. The OB-GYN provide the option for the mom and for her husband, if you want at the time of the delivery for your newborn to participate in the genome of newborn screening, then you have to consent. And we are willing to take the sample. And the sample is very easy. We don't prick the baby. We don't scare the baby. We don't scare the mom. It's just a sample from the cord blood. And the cord blood and the placenta, they will be thrown anyway. So it's a great, let's say, treasure that must be utilized and for the benefit of the people. And usually this process, it's collected by staff nurses in the labor room. And no sample should be collected before checking that both parents have consented with agreement for participation. We have the other cohort, which is the newborns, meaning they are sick babies for one sort of reason or another, with the exception of congenital cases. We only select, with the help of our neonatologist, the cases which are harboring or red flagging there might be some genetic disease component in that sick child by signs and symptoms and the status of that newborn. If the newborn in the NICU has a central line or IV connected, then we don't do a new prick. It's just from that open line. And the approval is taken from 3, both parents and the attending consultant neonatologist. So we have finished phase 1, which is a pilot from governmental hospitals. It was completed last year, and this year we are planning for expansion to cover all of the newborns in the private sector, all of the deliveries actually in the private sectors, with a starting line from December, but whenever you are ready, even now on November, we will be more than happy to launch that. And of course, all of the participants during the consent and even after the consent will ask the famous question, will I get the results of my child? When will I get the results of my child? So there are 2 answers for this that must be understood by everybody. The first part is that the National Genome Center is a research-based center. So if there is any clinical urgency for whole genome sequencing or panel or single gene, then it must take the clinical route through genetic testing. Do not wait for the research program to release the result if there is a medical urgency and emergency for that. Meaning we will build up our own local capacity. We will try to fasten the analysis process as much as the time allows. And it's a project of priority. And it will take the same route as the adult or the Bahraini Genome program. When the results start to appear, we will start to return the results with actionability and emergency for families and babies. So this project cannot be done only by us as Genome Center, not only by us and our collaboration in governmental hospitals. We need all of you here in this room. You are all ambassadors for the National Genome Center and for the Genomic Newborn Screening Research Program, because knowledge is power, and with that power, you can convey the message to those who are in need for genetic testing and they don't have, let's say, accessibility or financial ability to afford such testing. Even if they require it in the future, you never know. At the end of the day, it's an art of uncertainty. We all came to this world healthy, looking fine, but along the way, there have been some health pitfalls that some of them might have a genetic component. And in either way, when it comes for newborns, the placenta and the cord blood would be thrown away. So why don't we use it to the maximum and unlock the great potential of this genetic knowledge for us and for the generation and the country? So I have submitted the informed consents for the newborn genomic screening program through Dr. Qasim. And the very great news is that the adult genome program is exclusively only for Bahraini citizens. But the newborn, on the other hand, is wide open opportunity for residents of Bahrain, meaning non-Bahraini and Bahraini. We are taking both samples from any nationality when they are newborns only. And with that also comes a lot of, let's say, common questions, which I will address also shortly. But you are all here today for this opportunity to convey it to your patients, to your families and friends, and to plan it forward for the success of this program. So the informed consent should be available in antenatal visits, labor rooms for those who missed the chance during the antenatal visits. They will still have the opportunity to participate and give the sample of their newborn, and also in the NICU. It will be collected by staff nurse at the labor room, the midwives, and the delivery. For example, you are here in Bahrain Specialist Hospital. Our Genome Center is in Public Health Directorate in Salmaniya area, opposite to Water Garden. So all of the private hospitals and all of the laboratories around Bahrain are sending us samples on daily basis for public health laboratories. So you can store the samples and collect them for 3 days. For example, some deliveries happen over the weekend. You can keep the sample in refrigerator along with the consent and send it on Sunday along with the other samples from the other departments to public health laboratories. This is our National Biobank repository. All of the samples are treated accordingly, and each number is representative of one participant. And we have successfully collected in our biobank around 60,000 samples from Bahraini population. And the number is going on. And our aim is to reach 100,000 out of the Bahraini population, 1.7 million. This is the consent for the genomic newborn screening program. We have two versions, the Arabic and the English one. I just put a screenshot of the consent for your reference here. But the most important part of the reference is that the parents read it carefully, and the midwife or the OB/GYN doctor explain to us and address any concern for those participating or willing to participate. And at the end, there is what we call in Arabic affirmation or al-iqrar, which we take signature of the staff nurse and one medical witness and both parents. And for the staff nurse and the medical witness, there has to be included the number of NHRA license, besides the place, date, and time. These are the contacts for the mom and the father, and the email and the contact number. So in the future, when we get ready with the results, we can contact them through their numbers. So since genomic medicine and all of those genetic testing are new in the field, some new dilemmas and social concerns might arise from those who are willing to participate. Number one, they always ask, will I be paid by you to give you my own sample or my own child sample? No, it's completely volunteer. If you are willing to participate, this is for your own benefit, for the country's benefit. If you don't want, it's okay. We cannot force you, but we are not paying any money for the participants or their parents. There might arise some language barriers and term difficulties because not everybody knows what a gene is, what genome is, what genetic testing is. So we have to break the ice with the audience or the participating and allow them to digest the knowledge like in 1 or 5 minutes of explanation. I want to also emphasize on this because we have faced it so many times in genome campaigns and in governmental hospitals. Some of the participants might become a bit aggressive because they have some remainings of COVID era and COVID years when they think that we are doing something against them or against their children with the genes, and we are studying them to develop some biological weapons. So we have to fight conspiracy with knowledge and literature. And no, we are not developing any weapons. We are just trying to steer the wheel for more proactive healthcare system that prevents diseases and help you and your own family to have a healthy family members and healthy life. There are some also religious conflicts which have arisen from both Arabs and non-Arabs, Muslims and non-Muslims. Some of them, they say in particular these phrases, this is in Allah's will. So why we are interfering, why we want to know, why you want to know about us? And is it revealing or interfering with destiny? No, we are not interfering with destiny, but I will show you a very short clip which defeat this idea. Confusions. Some people are confused about the types of screening and the types of genetic testing. They think that the repository sample in the biobank is equal to stem cell therapy in the future. For example, if the child in future, God forbid, got leukemia and the child needed, for example, bone marrow replacement and therapy and needed fresh stem cells from a donor, why to go to a donor? Let's go to the Genome Center. No, it's not the same thing. It's totally different. Stem cells are one thing, and keeping a small sample from the cord blood for whole genome sequencing is something else. We are only looking at the health aspect of this individual and how it will affect the whole healthcare system in the future. And if a disease, a genetic disease was detected, they will be informed about it and they will be enrolled in early surveillance and treatment programs within governmental hospitals. Technicalities, allow me just to go through it briefly. Each participant, whether adult or a newborn, will require 2 tubes, EDTA, tall pink, 8 millimeters each tube. And those timing issues I've already explained earlier. If you have any question from the participants that you were not able to answer, you can forward the question to our own emails, or you can disseminate my own number. I am the hotline to answer all of the questions. Also with me here today, my colleague Shayma, she is medical technologist and she is responsible for almost the 50K whole thing. All of the blood withdrawals, they were done all by her. So this is the film which I have told you about. Just allow me to go back through the pictures. The 2 tubes will be in a specimen bag. In this specimen bag, there is a pocket. In the pocket, you also insert the informed consent. So when you send it to the public health laboratories, we receive the whole thing, 2 tubes and informed consent. We do not accept any tube or any specimen, even if it was labeled, without the informed consent. If it came without the paper, it will be thrown away. And also some good news, we will go paperless by next year. The informed consent will be done through the IGA, electronic government system, just like COVID, just like any other issuing official papers. And it will feed us directly in the system at the Genome Center. But for now time, we are using the papers.
Today, a devastating attack. This week we know
she diagnosed something type 6 months of age. She passed away at 15 months old.
This is a disease that is devastating infants. A large percentage of patients die before 1 year of age, but 95+% are done, unfortunately, by age 2.
SMA rapidly robs babies of their ability to move, talk, swallow, and eventually breathe. When Milan and his wife Elena found out they were pregnant with their second child, Evelyn, they prayed for a healthy baby. Unfortunately, that was not the case.
She was born, and the results came back, she was positive for SMA type 1. And we both kind of just broke down. We found out about the clinical trial here at Nationwide Children's Hospital.
This is really the first time that we've been able to apply gene therapy to any neuromuscular disease.
Today was a very special day for Evelyn. She was given genetic therapy for her missing SMN gene.
Babies with SMA are missing a gene vital for development. Through a one-time injection, gene therapy replaces this missing gene. For Evelyn, this gene therapy worked.
We started seeing changes as early as 2 months after treatment.
Started to push, and she started to get more active, holding her head up, and A little after 3-4 months, she rolled over on her own.
Now, 3-year-old Evelyn challenges Dr. Mendel to a dance-off at her annual follow-up appointment.
She comes back after 3 years and she runs up to me and hugs me and says, Dr. Mendel, I love you.
I forget that she's SMA. This is a healthy girl, and she does everything that a normal 3-year-old child would do.
Something like that has never been achieved before.
Well, with our first audit, it was just devastating to lose a child. You lose all dreams you had for their future. And now we can actually save for college.
Spinal muscular.
I think the message have been delivered. You all now appreciate the difference between a life that could have been lost and now available. Forgive me, this story always touched me. Anyhow, gene therapy is not far away, but it requires acknowledgement and genetic testing. Nobody can receive gene therapy, without knowing the genetic underlying disease and the diagnosis itself. So it holds the future of curing instead of just regular management or treating the symptoms or just prolonging the life without a quality of life. Where are we now? We currently started in Bahrain gene therapy for sickle cell disease. We started with low number, 1 patient only, still under a clinical trial. For this particular disease, which was shown to you in the video, we have cases of SMA, but currently we are sending them for treatment outside of Bahrain. But with our National Genome Center, we are also planning to do everything in-house, including gene therapy in the future, inshallah.